Hello, hello, take one, take hello. Hello, 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 hello. Check one, two, three, check. Hello, hello. Start. Good afternoon, one and all. From Department of Plastic Surgery, Jitmer Pondicherry, we welcome you all. I request all of you to rise for the prayer.
धन्वन्तरी स भगवानमृतत्वदाता यो वैद्यकस्य गुरुरादिरनादिकालात् यो हार्तदेगमन आत्मसुखावहस्य नैरोग्यतस्य निधरां च नृणां हितस्य तस्यारणास्पदमहर्षिवरस्य शिष्य ये त्रेवयं प्रमुदिताननुभाग्यवन्तः देन प्रतीपितचरं सुचिरात् शुभायुः वेदस्य दीपामिह तत्पुरदोतरामः येन प्रभां वयमिहस्य विदद्य दिक्षु ज्योत्स्नां रुजातिशमने प्रभवेम दातुम् व्यादिव्यकात हृदयाय मानवाय देयं द्वितं भुवि कलापि च न किलैषः देयं द्वितं भुवि कलापि च न किलैषः देयं द्वितं भुवि कलापि च न किलैषः
Now I request our Assistant Professor, Dr. Padma Lakshmi, to welcome today's guest speaker, Dr. Shindar by Bouquet. By Brown. You're too tall for me. Yes. The advantage of becoming small is you have to give people go. Yeah. Yes, okay. Just give me now. Sure, sure, sure.
On behalf of our
Yes.
assignment,
On behalf of
very cordially invite and welcome
yes,
our chief guest
yes,
and speaker, Mr. Sridhar sir.
yes. Welcome to Pondicherry. Welcome to JK. Thank you. So this will be the our program, today's program, and this is the overview. We will be covering two recent aspects. One is related to dressing material, which is very common for an important for plastic surgeon, and then another common problem is the vacant axis. So these two important topics we have taken today, and this is how we will go about it. And before we go to the scientific program, now we would like to inaugurate the officially this program, and I request our guest speaker, Dr. Sridhar, and our faculty, Dr. Padma Lakshmi, to join and light the lamp. Ladies, please. अरे प्लीज का So this is our ongoing series of guest lectures which we almost conduct every month, and we invite our eminent speakers to give their experience and teach our students. So this program is in hybrid mode because JIPMER is the Regional Resource Center for Telemedicine. So it is being like in other countries, including BIMSTEC countries like Bangladesh, Myanmar, Bhutan, Nepal, Thailand, Sri Lanka, and also other European countries with which we have MOU. And we have 160 medical colleges which are under the JIPMER as a mentor. So we freely link and they are watching remotely. So I welcome both the physically present participants here and the remotely attending. So as I told, this is the overview of the lectures and the program. So I have taken this topic, which is very common for resident and but taken very lightly. They think dressing means just put something in the wound so that something will happen magic, but actually nothing happens unless you make it more scientific and preferably if it is can help in regeneration in nature. Otherwise, your gauze piece is like simply a dress which you are wearing. It will just cover it. So this is a simple dressing. Usually, we as a surgeon or the resident, we will use some material, and typically it is a gauze piece or paraffin gauze, which is clean and sterile, and it is usually directly covers the wound, and the purpose is same, which is common for all the dressing. Either we want to cover the wound from trauma, or by chance if you have put some medications, it will deliver some medications. But the difference lies when you add on regeneration part. There lies the difference. So a common dressing versus the regenerative dressing. That is our main uh, topic of discussion today. So when you say regeneration, it will regenerate the wound bed. It will regenerate the particular tissue or a bodily part. Then you can say it is a regeneration. Otherwise, it remains as a only cover. And the when you make a dressing regenerative in nature, you have to take the help of some tissues which may be in allogenic, means other humans, or xenogenic, which may be animal, and they must have some sort of a extracellular matrix so that they will allow the tissue to regenerate. So the part which will directly come into contact will be the primary dressing. And that is the part which should come directly to the wound. If it is not coming in contact with the wound, then it cannot allow regeneration. So then it will remain as simply a cover. Whereas over the regenerative dressing, you can do a secondary dressing. And that secondary dressing can be anything which you want, a bandage or a gauze or a negative pressure, or so those will be secondary. But the primary dressing has to be in direct contact with the wound and it must allow regeneration. That is the fundamental basics of. So this regenerative dressing is now called as a scaffold. What we used to call it a dressing, people should understand the difference between a dressing and a scaffold. A scaffold is also dressing, but dressing cannot be a scaffold. Why? Because scaffold, as it will get over the time absorbed, the host tissue will improve. The strength of the host tissue. Whereas in a gauze dressing, gauze is not going to be absorbed. Gauze will remain there only. Whatever the gauze you are putting, you open after 7 days, gauze will remain there only. Gauze will be there only. But when you open after the regenerative dressing, you will realize it is not there. That is the difference. So when you design a regenerative dressing, you have to ensure that when you are putting over it, it must get infiltrated with the host tissue. And over the period, it get absorbed or what we call degradation. Now, how much it will degrade, at what rate it will degrade, that depends upon the type of scaffold. So, as I told, you can have a scaffold as simple as if you take the relative skin, it is not going to take. Even if it takes, we don't want it to take. So there will be epidermis, there will be a dermis, but it will allow regeneration faster than a simple dressing. Similarly, suppose you take a placental tissue. So placental tissue is a source from human, is also allograft, but it will allow regeneration. Similarly, animals, which can be a murine, porcine, bovine, avian, they have a collagen in their body. So the next is the animal, then birds, then plants, and now the new thing which is coming up is the microbes. So this topic will be covered by Dr. Sridhar. Why? Because when you say cocoa heel or the coconut, so they take the coconut water and they ferment it with the bacteria, and then a sheet is formed. So microbe is the another source of preparing the scaffold or a regenerative type of. So as simple as if you are having a collagen sheet or a amniotic membrane or a non-cultured keratinoid sac suspension, or you have taken the dermal matrix from the patient. These are the single layer. These are single layer. Over that you will be putting secondary layer, secondary dressing. But scaffold can be 2 layer also, or even 3 layer. If you see commercially available, two sources are there, Integra, BTM, there are 2 layer. But now you can have a 3 layer also, even the 4 layer also. So dressing, duration of regeneration, the effectiveness will be more long. You are allowed to, even if you put it on an infected wound, a simple 2 layer will get absorbed very fast. But if you have a 2 or 3 layers, probably absorption will be there, but duration can be kept longer. So these are the possible combination which you can have commercially, or you can prepare yourself indigenously. So these are the list of commercial regenerative dressing. They are supposed to help in the regeneration, and some of them are exclusively for dura or for neurogenic tissue or for eyes or for cornea, and for plastic surgeon for all practical purpose skin. So these are so many commercial preparations are there. You have to ensure for what purpose you are taking it. So here we don't use simple dressing. Our dressing is always simply putting a silver sulfur diazine dressing or a betadine dressing or a, so these are only antimicrobial in nature. They will never do regeneration. In fact, they hampers the regeneration. So at the cost of killing the bacteria, you are reducing the regeneration. So that is the problem. So we want that it should not only cover, it should regenerate, and over the period, it should do wound bed preparation so that either the wound will repair itself or you will reconstruct by cover. So I'm sure right from your MBBS time, placenta can be harvested from the labor room under all aseptic precaution, and amniotic membrane, umbilical membrane, cord membrane, all this thing can be removed. And now they are using the even chorionic tissue also. In our time, we were using only amniotic and umbilical cord membrane. But now the grayish chorionic tissue is also now commercially available also is available. So why you need to purchase? You see, it is like a collagen sheet, but it is amnion. But it is better because it's human source compared to animal source. So these are various series of. So as I will tell you, this is a antimicrobial coated, human derived and dried. So this is a commercial preparation which we use in this. But in a government hospital, it is very difficult to. So it will help in the superficial burns to heal, and deeper will be getting ready for the cover by SSG or flap. So superficial area will heal. This is another amniotic membrane. Another membrane. So these are some of the example we are giving, but daily we are using so many patients. Some of them are reported by our resident as a case reports. So we are showing. So these are the standard way of applying the amniotic membrane for two purpose. Superficial area should heal and deeper area should become ready for cover. These are the all the done by our residents. Then the another source, as I told you, is the animal source. So egg membrane is supposed to be regenerative in nature. So you are having a kitchen in your department, dietitian is there, you can and you are giving the egg also to the patient. Why don't you harvest the membrane and use it? So when I came across through the article that egg membrane is also commercially available, then why we should buy commercially when you can freshly harvest under all aseptic precaution? This is a difficult thing. Simply, but it will come into, not as a sheet. It will come into pieces, but small wound, superficial wound mixed with the collagen, you can always use. So you see in this photograph, you can see this is very large one came. So while you are removing it as a boiled egg or as a unboiled egg, depends upon the how you are taking it out. See the small area. Suppose collagen is not there, but egg is there. Egg is always there. Why don't we use that also? And all this thing after going through literature, we start also using it whenever it is. And then another one is the collagen. Collagen everybody knows. This whether it is a provide so much for coinciding source, dry or wet, mashed or non-mashed. So granules will be for cavity wounds because difficult to pack the sheet. So that is how it will help in the regeneration. Another example of collagen granule. Then collagen cream. The collagen cream itself acts as a layer. Over that you can apply the secondary dressing. Over the period it will regenerate. Donor site, as you know, commonly. So wound can be anything, burn or trauma or diabetic foot ulcer, but you must use the regenerative scaffold dressing. Now this wound, suppose it's a deep wound and you are waiting for the, getting ready. So you need to fill it so that granulation will come and then you do the flap. Electrical burn, deep wounds, and then finally you can cover with the graft or flap. Another example of collagen cream. Necrotizing facial. So you don't allow it to get more infected and more. So better you cover with the biological scaffold dressings. And then another source is the cadaver. Till now it was live. Then now cadaver also. So cadaver skin also human live skin or cadaver skin you can use. This is live human skin, cadaver skin. So any patient who expires, take a consent, harvest it. So this is a patient of electrical burn with his sternum exposed, and he had bilateral amputee, and later on we did reimplantation, bilateral limb implantation, our first case. But he should have first survived with the burns and the infection and the septicemia. Then only you can plan the reconstruction. So it means cadaver skin is also useful. Similarly, you can harvest blister or bullage by suction method or fluid method. So that area is very superficial, it's like abrasion, it will heal. But when you cut it into pieces or directly apply, it will help in the regeneration. These are the ways of using the regeneration sources. Another small wounds, another wound. Then what you can take small 1 centimeter, 2 centimeter harvest skin and crush it into minced graft and apply as a paste or put it into a spray bottle and spray it over the donor side or any wound. So here the regeneration will be faster. Why? Because cells are there. So you can use minced epidermal dermal graft. Pixel graft is also small. Make it more small. And you can see very small. So donor side will be hardly visible. But the pixel means like computer has a pixel. So here 7 cases reported. This is Padma Lakshmi has reported. You see, Padma Lakshmi name is there. This is a PubMed journal, pixel graft. When she was resident, we keep telling them, please do it, publish it. So silk is another source. Cocoon silk. So silk also has a regeneration. Why I am telling you, these are multiple sources of regenerative dressing. And then patient relative skin. So life skin. Now 2 layers. 2 layers means you can take the collagen which is commercially available and you can take a small dermal extract so that you will have a 2 layer. Collagen will act as a carrier and dermal extract will be directly in contact with the wound. Again, collagen plus dermal extract. Another collagen plus dermal. And this is we have prepared ourselves. Our resident scaffold, you can see it's indigenously prepared. The sutures are there. So what he did, he took the collagen sheet and over that pasted and suture it and then apply it. Now collagen plus amnion. Take a amnion, take a collagen, join together, stitch it, make it like a scaffold and apply it. Collagen plus dermal extract. Collagen plus dermal extract. These are all done by our residents. I don't allow them to do simple dressing, daily dressing. It's not going to serve the purpose. Little bit of extra. So here it will be shown also how our resident prepares 2 layers, silicone and collagen, as I was telling you. You see, they have sutured it. Simply take a silicone sheet, silicone sheet, which we are using for stickability. Over that, 2 to 3 collagen sheet becomes filigree. Filigree is also after the silicone, and inner layer is collagen only. What is so great is that? So the scientific remains same, but it become indigenously cost effective. So like that, we have been using for the different patients. Similarly, collagen plus pixel graft. So you can see the small pixel graft, and this is 10 number of patient he reported, Vinayak, and he has put it on the. You can see this is the collagen sheet. So now you hold the collagen sheet and apply. So collagen sheet will act as a carrier, and this pixel graft will be in touch directly with the wound, and it will allow regeneration. Then another one is like BTM. This is the commercial preparation, BTM. So scalp wound is there, wound is not ready for the cover by flap. So what you will do? You apply the commercial outer layer of polyurethane and the foam matrix. Another one, this is by Padma Lakshmi, Tendo at least. She published it also, I think, in IJPS, huh? IJPS. Then you can use it even avoids nail. So nail is lost. Now every day you have to do dressing for this nail, and with the speed it will take 2 years. Whereas what we do, we make it and we use the BTM suppose. This is commercially available because patient could afford. But if the patient is not able to afford, you make your own BTM by silicone and collagen and fix it around the owl's nail and leave it for 1 week. Every 1 week, 2 week, whenever the patient comes, you change it. And you don't have to lift it. You keep it on the matrix side close and only the little leg you lift it. So patient feels a little protected, can wear even the shoes also. So this is another indication for scaffold dressing. So silicone plus collagen, Integra. In this patient, we have used commercial Integra. And then 3 layer, outer layer of silicone, then collagen, then amnion. So it became 3 layer. It is shown also. The first layer is second layer, third layer, and then you apply it. Indication can be anything. 3 layers. There are so many. Just the examples. 3 layer, all 3 layers. Now 4 layer. Even 4 layer can be made. So you have an outer layer of silicone, second layer of collagen, then take the amniotic membrane, do dermabrasion, and take the keratinocytes and spread it. So now you will see you have a 2 or 3 component. So directly contact is the human tissue. NCKS is the non-cultured keratinocyte of the same patient. Then there is a allograft, means amniotic membrane. Then there is a xenograft, means collagen. Then you have a silicone, which is synthetic. So 4 layers. But the direct contact is always with the autologous tissue. So you can make your indigenous 4 layer. So these are the steps how you will simply take a silicone sheet, then take a dry collagen sheet, which automatically gets stuck. You can take 2 or 3 layers because it will be very carefully like a tissue paper. If you want to make it 2 3 layers, yes, you can make 2 3 layers. When you prepare it, 2 layers are ready. Once 2 layers are ready, prepared by our resident and then you spread the amniotic membrane over that. Third layer, harvest from the placental tissue, this is the amniotic membrane. Then the non-cultured keratinocyte suspension, which is negative after doing the dermabrasion and you spread it over that. So there is a cell, the sheets, both are there. So this is all I have told about the various kind of regenerative dressing, single layer to 4 layer. But yes, if you use commercial or synthetic or there is a possibility of reactions or donor, they are not ready to give their skin, whether live donor or cadaver. And of course, there will be, if you are harvesting from the mother or relatives, there will be donor side morbidity and commercially cost is the problem. But whenever it is possible, always use the regenerative type of. So this is the purpose. Not only should simply a dressing should not just simply cover it. It should regenerate it, prepare the wound bed for reconstruction. Thank you. Uh, Questions and discussions we'll have at the end of the all the lectures once get over. Then we'll be taking the questions. And those who are online, they will put the question in the chat. We will take it one by one. So now our next talk will be given by our guest speaker, Professor and Head of the Department of Plastic Surgery, Omandur Multi-Specialty Hospital of Tamil Nadu government, Chennai. So it's my privilege to introduce Dr. Sridhar, who is MBBS and MS from Kilpauk Medical College and MCH from Stanley Medical College. And he has been in the Tamil Nadu government service for now 28 years. And he has in this period worked as a tutor, assistant professor, associate professor, full-time teacher, and currently he's the professor and head of the department at the multi-specialty hospital, Umandur, Chennai. Of course, sir has an interest in the cosmetic surgery also and hand and reconstructive surgery. Sir has won two important medals. One is the Nagarajan Memorial Gold Medal for General Surgery in 2003 and C.R. Sundarajan Medal in 2007 for presentation on nasal reconstruction. And then he completed his Ethicon Fellowship also in 2011. And like any senior professor, he is member of various national and international association and has held the position of organizing secretary also in TANPAPS 2024 and ISSH Con 2020 and secretary of TANPAPS from 20 to 24. Has got many national and international publication and has also participated, presented, chaired various sessions, conferences, workshops, and courses. And he's a trained and professional player of South Indian percussion instrument. That is his hobby, and he's another hidden art. And these are the various paper he has presented over the years, and these are the publications that has done. And he has a vast teaching experience now of 28 years, and the position which he has already held. So, sir, over to you. We welcome you to give your first talk on the micro-based regenerative in nature dressing code. That is why I did not cover, although we are using it. We are already using it. We have sent for publication also, Coco Hill. But I did not cover why because you are already covering. So detail will be told by you, sir. Welcome, sir. Please over to you. And second talk, sir, will be giving on birth brachial plexus injury, a race against the time. Sir, over to you. Just nice and open the sir's speaker.
By the time this is getting opened. Good afternoon, everybody. As I had a great introduction from the Professor Ravi Kumar Chitoria, sir. Thank you very much for those kind words. I would also like to thank Professor Mahapatra. Dr. Dinesh, I know him for quite some time. I've been friends with him for, I think, since 2005, 6, almost 20 years now. Dr. Friji, I met him in the conference. He's a very nice person to move with. And Dr. Padmalakshmi. And all the members who are part of this session. Thank you very much for inviting me. There'll be two topics I'll be covering on, one on biocellulose occlusive wound dressing, and second is on birth brachial plexus injury. I finished from Stanley Medical College, so my passion is towards hand reconstructive microsurgery as well as brachial plexus injury in particular. This topic I'm taking on behalf of the product, Coco Heal. This, as you would have seen, this is the primary product. It is prepared from coconut water and virgin coconut oil, and they make it into a sheet. Okay, this is just to give an outline of what it is primarily. What it does, sir has beautifully put it across all layers, first, second, third, fourth, so many layers, so many dressings. And this, I feel, is across the Southeast Asian countries, lots and lots of coconuts are available. So I think this is a safe product, biodegradable product, and it is not harmful to the tissues. Okay, these three things I would like to put across first. And second, as you're seeing in this picture, the primary content of Coco Heal is monolaurin. Okay, this monolaurin has been integrated with cellulose to make it more functional, to make the basal tissue on which that you're applying to have a good regenerative potential, as sir has previously put in. First, either it allows the wound to heal or it prepares the wound for us to do a secondary cover. Both are possible with this product. And not just that, it has also got antimicrobial function also. You can see the functions that are happening, cocoa heal and the organisms that are there. You can see that the inhibition that is happening for the organisms, you find that this is more functional in Propionibacterium acnes and Candida, both not just the bacterial but also fungal, all are happening. And this is working against Staph aureus, E. coli, Candida, as well as Propionibacterium acnes. Particularly more so, it works with MRSA also. So on that front, it is fine. So where would you like to use it? As Sir has put in, there are many ulcers that we are trying to treat. In our country, diabetic foot ulcers are a major component of this. Then you have burns, then you have pressure ulcers and venous ulcers. There are some ischemic wounds, surgical wounds which fail to heal or which take some more time to heal, and a containment of CSF leak. All these places, this cocoa heal can be used. What is the advantage of cocoa heal? For this, I primarily recommend for use in small to medium-sized wounds. Large wounds, this takes quite a long time to heal, but small, medium-sized, resistant, recalcitrant wounds, these are very good products. And whenever the exudate coming out of the wound is small or the quantity is moderate, this really works well. It is a high exudating wound, it takes a longer time to run. So you choose small and medium-sized defects. You choose small or moderate quantity exudating wounds. This is an ideal secondary dressing that you need to apply. You can see it absorbs the exudates. As you can see in the picture, that this much will get absorbed. The latest one that I did was yesterday. I had to remove the dressing. Normally, it is retained for about 2 to 3 days. Sometimes you can stretch on to the 4th day. But by the time I had seen this patient did not turn up for 4 days. 5th day, when the patient turned up, absolutely nothing is there. Only a thin collagen sheet-like thing is there, which means that it is absorbed into the system and it makes the matrix bed into a greater region potential. There is less inflammatory infiltrate, and there is organization of collagen bundles in such a way that the secondary work that you need to do to cover these wounds are also happening good. And early granulation tissue, more often than not, you find the other products. Sir was talking about amnion, chorion. Now they have come up with combination of amnion, chorion in the form of powder, in the form of sheets. Many things have come. Brilliant granulation is coming out of those things, but granulation with some infection is possible in that. Here, the infection is much less and adequate granulation comes so that secondary cover becomes much more easier and the scar is reduced. It is an excellent skin substitute and it has got good barrier properties. The absorption of exudates for small to moderate quantity of exudate, it is really good. Water holding capacity is really good. It accelerates the wound healing. If there are defects which are small, 1 centimeter, 2 centimeter, spontaneous healing is possible. When it crosses the 2 centimeter barrier, it prepares the wound for a secondary cover. And biodegradation of product also happens, and it is less, or you can call it as non-toxic to the environment. It is available in various sizes, 5 into 5, 10 into 10, 15 into 20. And what is brilliant about this is they have got a 5 into 5 centimeter sheets, and those are available as 10 different sheets. So a patient buys this, a pack of 10. Every dressing, that individual 5 by 5 can be used. It is non-contaminated. You don't have to cut it into pieces, and it is absolutely sterile every time you use. By about 3rd or 4th week, small wounds completely heal by themselves. How to apply it? It is actually a simple, easier way to apply. Clean the wound. If there are dead tissues, debride those. There is nothing matching a surgical debridement. So please do a good debridement. Make sure that 90-95% of the dead tissues are removed. For the remaining, you're going to apply. It is available. There are 2 layers before you open up the cocoa heel. After the outer layer is open, there's an aluminum foil. Then you open it, and inside you see the cocoa heel product. It's actually really soft and it feels like tender coconut. The moment you see it, it feels like that. Do
Jelly,
not
like
put
a
it in your
jelly.
mouth. It is, it is very tempting. It looks like a tender coconut. So it is very jellyish. All you have to do is clean up the wound, apply the cocoa heel, spread it evenly. Do not leave it uneven. Spread it evenly. You don't have to fix or anchor it. Do a secondary dressing, fat bandage roll. That is sufficient. And these are some examples of what can happen with the cocoa heel. This you can see is a diabetic wound. And this patient is a diabetic for about 20 years. He was suggested amputation. We find that these are small, multiple wounds. These have been debrided, and after a good surgical debridement, only dressings have been done. And with dressings, by about 4 to 6 weeks' time, which shows tremendous healing, no secondary grafting has been done. All these wounds are in the range of about 3 to 5 centimeters in size. This is an example of a radiation burn post malignancy treatment. You find that the skin is a little darker, a little, you feel that this may not heal well. But with cocoa heel dressing, which is providing the moisture to the wound and also preventing organisms to grow, it allows the skin to re-epithelize by itself. And this is in about 3 weeks' time. You can also see such healing wounds in superficial burns by about day 8, which is on an average, first degree, second degree superficial wounds, they heal in that first week to second week, 7 to 14 days time. So by day 8, you find that small dots of dermis has come back, epidermis, small dots, and by third week, it is almost completely healed. And this is an example of a venous ulcer. Venous ulcer, very difficult to treat. Simultaneously, you are offering treatment towards management of the varicose veins as well as management of the wound. Only dressings have been done. By about 3 to 4 weeks' time, you find that this has epithelialized completely. And this is an example of a diabetic ulcer. A debridement has been done. On top of it, only dressings have been done. Patient was not willing for surgery and also had complications like cardiac problems where patient was not fit for surgery. So till the time we could take up for surgery, we did the dressing. As the wound was beginning to heal well, patient found it very comfortable, did not undergo any surgery, and he has reached up to these levels. And this is a lady with a diabetic foot. Great toe is amputated. You can find lots of sloughs over there. Patient is on a non-contact cast, and the wound cocoa heel was applied. 2 dressings. The wound is ready for a closure, and in about 8 to 10 days time, only 2 dressings were done. In 10 days time, wound is ready for closure. We have closed the wound. Patient is on her foot. No more POPs. Patient is on her foot by about 6 weeks time. This is a neuropathic ulcer, peripheral neuropathy, diabetes. This is small. After debridement, cocoa heel was applied. This is the patient that I have the photograph in my phone. Sorry, I've not transferred it into the presentation. This patient has had a significant shrinkage. The whole content was absorbed. Only a thin layer of a transparent dry collagen sheet kind of thing only was there. The whole thing was absorbed and it has settled well. And these are difficult patients operated twice, thrice with grafting done elsewhere, comes to us with these kinds of wounds. These are ideally suited wounds for cocoa heel. Thank you very much for giving me the opportunity to speak. I would like to thank Cocoa Heel for this. And it's a product to be used for small to medium-sized defect with small to moderate quantity of exudation. It is an ideal wound. It will heal the wound and it will also prepare the wound for a secondary cover. Yeah, I think as Sir has said, we'll have the questions at the end of the session.
Sample, can you show that one sample, just small size, not the big one. We will not waste her, but anyhow we will use it also. Small sample, just to show the our staff nurses and residents, those who are not. Most of those people have seen it. Because the camera, this big size, small size not there. No, don't open. Small is not there. No.
We have to.
Today we can use it. Yes. So as sir was saying, these are the multiple, it's like a jelly.
So thank you.
Can you see this is like a jelly? You can just feel it everyone. So over the period of time, it will get absorbed and only a small thin layer will be left there. So that is what I was showing in the curve. That as it get absorbed, so the strength is coming. The spectral strength will come. Our residents have already used it, and those who want to go through the details, they can go through the detail. You can give it to us, we will use it. Because demo is also important. If it is available, people should not feel that they have not seen. Okay, so next lecture. Want a break or?
Yeah, we can proceed, sir. We can proceed. I'm passionate about this. I'm really passionate about teaching. In the same process, learning also about brachial plexus injuries. I was asked on what topic, whatever topic you would like to choose. I've been working on this for almost 20 years now. Uh, what I have learned over these years is how important it is. And pardon me for telling this, I've had many patients coming from JIPMER to us for managing brachial plexus injuries at several points of time. Immediately, 1 year down the line, 10 years down the line. So they keep coming. It is a difficult and tough topic. Pardon me if I am sticking on to the basics. I would like to first create an awareness about it, one, and second, what are the options that are available in managing birth brachial plexus injury? This is my aim of the talk. Okay. It's a beautiful, intricate, and a complex structure. If you understand the anatomy, if you understand how to examine a case of birth brachial plexus injury, you will be able to master it, and you can offer something to these patients. Some basic history: people with birth brachial plexus injuries in olden days were thrown into a gorge. These children were thrown into a gorge sometime in Greece. There are many descriptions of birth brachial plexus injuries, originally termed as obstetric related brachial plexus palsy by Smelly. And then many attempts at surgery have been done. And after the surgery, they have lost children on the table. Immediately after surgery, all these are about 150 years back. They will operate without anesthesia. Surgeries have been done on these patients by Duchenne and Erbs. And Klumpke's has described the famous Klumpke's palsy of C8T1. Somewhere in 1920s, 70 primary explorations have been done at 3 months of age, which even now we hesitate to do because it was in the experimental stage. They also had some deaths. From exploring to converting it into tendon transfers in the 1940s to 70s, and from 70s till now, with the advent of microsurgery, surgery on brachial plexus injury has had a great transformation. What you're seeing here is a photograph of about 8 patients varying age, right from 1 week of age to about 17 years of age. So birth brachial plexus injury comes to us in all kinds of, in all ranges, all age groups, and in all possible layers of the spectrum. About 0.13 to 5 per thousand live births. It's equally seen in males and females. Right side is more common because of the delivery pattern that is happening. Bilateral cases can happen. This has happened in cases of breech presentation. The general belief is that 90% of the birth brachial plexus injury will recover spontaneously. This is what was previously quoted, and hence all the children were put on physiotherapy, evaluation by pediatrician, evaluation by neurologist. I think the current data is about more than 1/3 untreated will have lasting deficits with less favorable course. These children have to be seen by plastic surgeons within the first 1 week or 2 weeks to take a call on what can be done to them. Okay, if this is a simple thing to know, if you have a clavicle fracture, the birth brachial plexus injury is less severe because the toll is taken by the bone, the nerve doesn't take the toll. So if the child has got clavicle fracture, understand the brachial plexus injury that is present may be little less. What is the economic fit? Healthcare cost, workup cost, diagnostic workup cost, and a treatment cost. The indirect cost is all these children will have some kind of physical deficits. So they will have long-term functional disabilities. In patients in areas where there is a low resource setting, there is a disparity in access. Somebody who's got more income gets access early. Somebody who's got less income gets access. You will see it in the subsequent slides. And there is a significant delay in treatment. It has been called by so many names: infantile palsy, obstetric palsy, neonatal palsy, but the admirably fitting term is the birth brachial plexus palsy because it happens around the term of birth. That's why it is called birth brachial plexus palsy. The traumatic injury happens during a difficult childbirth. We've also had birth brachial plexus palsy in a cesarean section, which also tells us that it is not just the delivery which is important, the intrauterine maladaptation can also lead to birth brachial plexus injuries. The predisposing factors are large size of the baby, macrostomia. If there is a breech delivery, it has got a higher predisposition. If an instrument is used, more often than not, there is a higher possibility of birth brachial plexus injury. The primary problem is shoulder distortion. There are many risk factors to it. Of all the risk factors, I find that the cephalopelvic disproportion in a normal delivery is the primary risk factor contributing to brachial plexus injury. Some basic clinical anatomy, you would know it is from C5 to T1. You would call it as prefixed if it is going up to C4, and you would call it as postfixed if it is going up to T2. There are different nerve injury classifications that are available. Just a traction injury where nerve is not completely cut. There are some small breakages. If there is a breakage in the axon, it is called axonotmesis. And if the whole new nerve is cut, it is called neuronotmesis. You have the original sentence classification, then you have Sunderland's classification, then you move on to Mackinone's classification where there is a type 6 when there is a partial injury that is happening. The injury that happens, it is from C5 to T1. Most of the time, the upper nerve roots, you find that the ligament over here is bigger. The lower roots, the ligament over here is smaller. Because the ligament over the vertebra is a little thicker and bigger here, the injury happens at this level. The traction happens at this level. So hence, more often than not, upper nerve roots, you will have rupture that is happening at the trunk, more distally, not at the root level. When it goes to the lower nerve roots, because there is ligament is thin and it is short, the nerve is completely pulled from its root. So avulsions are more common at C8, T1 levels. And different types of injuries can happen. It could be avulsion coming out from the root. It could be a rupture. It could be a neuroma. There is a partial break and there is a traction injury. Different types of injuries can happen. The birth brachial plexus palsy can be C5, 6, 7, 8, T1. These are the 5 roots. You can have C5, 6, you can have 5, 6, 7, you can have C8, T1 separately. You can have involvement of all the roots with Horner syndrome or without Horner syndrome, depending on the involvement of the cervical sympathetics. So in an avulsion, you find that the whole thing is avulsed and it is coiled like this. When you explore the brachial plexus, you will find like a big coil like this, the whole nerve has come off. Sometimes in a rupture, there is a partial or there is a complete rupture. Both ends can be picked up. This is the Naraka's classification. And you see in this classification, the best of the lot is C5-6, isolated C5-6. And what he has given is spontaneous recovery in over 80%. It is never 100%. So any injury, even if it is isolated traction injury, the belief in the people's mind is it will settle down. The logicians, the pediatricians, the neurologists, the physiotherapists, all these people have an idea that this will settle down, do physiotherapy, do electrical stimulation, it will become all right. I think this should be taken out of the mind. First, it has to be evaluated by a plastic surgeon, and it has to be constantly seen by a plastic surgeon over a period of time to judge how much recovery is possible. In the subsequent slides and videos, you will see what small change can offer to the patient. It is difficult to examine the child. It is difficult to examine. You ask an adult to lift the head, lift the hand. Even then, some of them are less educated. They find it difficult to understand what we are trying to tell them. In children, it is all the more difficult. So what easily can be done is you can tickle the child. If the upper limb is moving less than what is expected, you think something is not all right with that. That's the tickling test. There's the towel test. You cover the head with a towel, the child tries to open it. You find they will use both hands. If both hands are all right, they will use only one hand, the other. If there is a brachial plexus injury, they may not use it. And if you have muscle function of power M2 at birth, it's a predictor for good prognosis. You follow them up monthly. There is a difference between a bigger child and a smaller child. In a bigger child, if you give a pen, there is a purposeful movement. The child understands it has to hold down to the pen, so hence it moves. But in a smaller child, you see that it is only spontaneous movement. The vision is not yet set in, so it will not pick up the pen. It will keep moving only the hand by touch. So it is spontaneous movements in infants, and it is a purposeful movement in an older child. And what you need to assess is the active movement scale in a newborn. Whatever movement that is happening spontaneously. When they reach that 3 months to 2 years, you have a separate Toronto test score, and all of us know what is a mallet scoring system. And this is ideally suited for children who are more than 2 years. There is a sensory scoring system by Naracus. And here you are seeing a projecting scapula. So this is called as putti sign. This is elevation of the superior medial angle of the scapula. This means that the elevated angle is scapularis is not acting, it is acting well, and there is an avulsion that is distal to the innervation of that. So here you need to do a supraspinatus slide. So if you are picking up this sign, if you do a supraspinatus slide, this patient child will recover. And children who have who are not able to abduct the shoulder much beyond the mandatory 90 degrees minimum, if they are not able to abduct further, if you provide them with a pedigree, they will be able to abduct, which means that the internal rotator is weak, and this child will benefit from a mod quad surgery. So deciding the clinical examination will help us to plan what we can do for these patients. The basic investigations would be X-ray. All other investigations are available. At birth, you would like to rule out other fractures, other injuries that these children have. 3D cis MRI means there is a constructive interference MRI, which helps us to identify the cerebrospinal fluid separately from the tissue. So if there is a pseudomeningocele, the CSF will leak and come out, you can pick up. And now what we are having is called as deficient tensor imaging or tractography. You can pick up the whole brachial plexus getting avulsed from the spinal cord. This is possible. What we do generally in the first week of life is radiograph to pick up other fractures. By about 3-4 months, it requires for us to make a proper evaluation in an MRI. MRI is possible under sedation. And this MRI has to be done by people who understand brachial plexus. More often than not, they do an MRI and they give a totally different investigation result, which we cannot match with a clinical examination. So that happens more often than not. So somebody who's well trained would be the right person. And as they age more and more, you may have to look at the shoulder and other parts of the body. And this is an example. Okay, this is a patient whom I have seen in the Kanchi Kamakoti Child's Trust Hospital. We have a scan center separately who radiologists who are trained in analyzing brachial plexus. So when they give the report, they will tell us what is happening at the root, what is happening at the trunk, what is happening at the division and cords. So when these kind of reporting system is available, you will be able to plan what kind of a management you want to do. The most important thing is a timely referral in managing this brachial plexus. And continuous follow-up is required till musculoskeletal maturity and optimal function are achieved. Non-operative treatment, this is importantly to be learned by staff nurses. More often than not, we have isolated C5, C6 traction injury where they go for internal rotation deformity. To prevent this internal rotation deformity, we need to provide them with what is called as a super splint. This can be very easily done. It can be done in the hospital, and the mother or the caregiver is the ideal person. If there is fracture at the time of delivery, you delay physiotherapy by 3 weeks. Allow the fracture to settle down. After that, you start with a galvanic stimulation and then progress to phanetic stimulation. This is an important splint. Please learn this. This is called super splint, supination, external rotation splint. You put the child in this splint. The internal deformity significantly comes down in patients with isolated neuropraxia. Surgical options. When would you like to operate on these children? If there is a global palsy, the upper limb is not moving at all, 3 months of age, you operate. If elbow flexion is 0 at 3 months of age, you operate. If shoulder abduction is 0 at 6 months of age, you definitely operate. And if there is glenohumeral dysplasia, despite providing them external rotation splint, that happens by about 6 months of age, then you have to operate. These are indications where you need to go in and operate. Do not wait for time, because time is essence. And I feel time is here, so important that you do early intervention, you get great results. The surgeries could be from exploration to neurolysis to nerve transfers to nerve repairs if you do it early. If you're going to do it late for children who are not operated or who are sequelae of microneurosurgery, 2 years, till 2 years of time, you have the opportunity window. Beyond 2 years, this window is missed. You have to go in for a contracture release, tendon transfers, osteotomies, or a free functional muscle transfer. This is essentially 3 to 4 hours of microneurosurgery. The anesthetist team have to be really good. They have to give general anesthesia, no relaxant. In a pediatric age group, they have to be well trained. So getting the anesthesia team is also important. Here, you see these splints, all these splints are advised in European and American countries. You find that is to be very, very cumbersome, very cumbersome. You find a simple arm sling is sufficient. Mother to take care of the child in our country does well. Post-op ICU care is required for about 3 to 5 days. Splinting and immobilization for 3 to 4 weeks if nerve graft or nerve repair is done. We start the electrical stimulation by 4 weeks and to 1 year. You can distract the child with something else and continue the electrical stimulation on the other side. Beyond some time, once they have the confidence, nothing will happen to them. They will cooperate with physiotherapy and electrical stimulation. It is a team effort. Pediatrics, neurologists, neurosurgeons, orthopedic surgeons, plastic surgeons, hand surgeons. And what I feel is message has not reached the physicians and surgeons. It is primarily a multidisciplinary approach. Each one has got a role to play. I feel the plastic surgeons have to take the lead in the role and get expert help at different levels with different consultants. This is a wonderful paper on race against time, and this lays stress on delayed complications in birth brachial plexus palsy and its management. This is a 16-year-old female recognized at birth only physiotherapy. We can see a lasting deficit in external rotation and supination. What you find as a problem here is this girl, finds it difficult to knot her hair to make the braids that she wants. This is unique to female children, and somebody else has been day-to-day activities. Somebody has been helping and going around. These are set of patients referred from Bihar. Third and fourth child, home delivery, untrained personnel. Same person has delivered all 4 children. Physiotherapy. You can see there is a lasting deficit in both. Both the children are birth brachial plexus palsy. One is 7 years and one is 4 years. Untreated, only physiotherapy. And dislocation of the elbow of the girl child. As a child, they don't understand the value of what they have lost. But the parents have traveled all the way from Bihar. There are many states from Bihar to Chennai. They could not get treatment, and all the way they came after seeing our results. One of our patients had gone there, shown the results, and then they are coming to Chennai to get treatment at our center. And this is an example of in a place which I was working previously. This is a 1 year, 4-month child recognized as birth brachial plexus palsy, evaluated and managed in a private hospital in Tanjavur, seen by pediatrician, neurologist, orthopedic surgeon, physiotherapist. From there, referred to Institute of Child Health in Egmore. From there, referred to MMC. From there, referred to CMC Vellore. And then finally came back to the place where I was working in Tanjavur Medical College. The primary problem is understanding what is this, how to go about treatment, and you lose valuable time. 1 year and 4 months. Nothing has been done to this child. And this child is now using the right upper limb as a supportive limb. Only the left limb the child is using. There is C5, C6, and partial C7 palsy. what I could do was basic investigations were normal, no pseudomeningocele, which means there is a rupture that has happened at the C5-6, not at the root, but at the trunk level. So I was working as head of the department in Tanjavur Medical College. The anesthetist, very luckily, the HOD of anesthesia was interested in pediatric anesthesia, was able to give this anesthesia. We were able to do exploration, nerve repair, nerve grafting, and electrical stimulation. All was possible. We can identify, stimulate each and every nerve, look whether it is functioning or not. If it is partially functioning, we can split it up into axons, find out which axon is working, which is not working, we can bridge with a graft. Children have the tremendous ability to recover. And this child, what we had to do was we had done a neurolysis from C578T1. For C6, we have excised and put a repaired the nerve, excised the neuroma and glioma. Child was with a lot of pain. And by what first week, second week, this is first week post-op, you would be worried it's happened to the child is jumping in joy. In about 4 weeks, we started with electrical stimulation and physiotherapy. What changed after this was all the people understood that birth brachial plexus palsy is operated by a plastic surgeon. We started getting referrals. 1 week old child, 2 weeks old child. We started now. We are at a burden of managing lots of birth brachial plexus injuries, and this change happened. And what it gave us was this is a child with the upper brachial plexus palsy C5-6. October 2019, I saw this child. It's a 2 weeks old child, and this is at 2 weeks. You find that there is no movement at all. This child is from Manipur. Parents are from Manipur. They had brought the child, and this is at 3 months. You understand that the hand is moving, the fingers are moving, elbow and shoulder not moving. This is somewhere in October 2019. I had operated in January 2020. COVID, 2 years, the child did not come. 22, they moved to Manipur. They had violence in Manipur. 22, 23. No physiotherapy. What I have done is exploration, neurolysis, and a nerve repair, excision of neuroma and glioma and a repair. At 5 years, this child came to me, no physiotherapy, left upper limb. She had an excellent shoulder movement. She could lift it up to the head. She could take it back to her back of the head. The only deficit that was present in this child was a very limited internal rotation. So all we had to do was to do a Mott procedure to get the shoulder into external rotation. Electrical stimulation is very important. Identifying each and every nerve, what function is present or not, that helps us in managing the patient. Sometimes you will require a nerve graft. Sometimes you may have to do a nerve transfer. Even if it is a small child, functioning hand is available, you can do an overlimbs transfer. They give excellent results. And this is a result of a Mott. This child had come to us with very limited movement. You can see that the shoulder abduction is present, but the typical trumpet sign is present. And this is after the Mott procedure. How spontaneously she lifts the upper limb so comfortably, and then the external rotation hasn't come yet. You can see she's using the other limb to take the hand to the back. And this, when they present late, with significant internal rotation deformity, after 8 years, I have a choice of doing rotation osteotomy of the humerus. Here, nerve transfers, tendon transfers will not work. My protocol is up to 1.5 years nerve procedure, 1.5 to 4 years you do Mott procedure to get external rotation and abduction. After 8 years, it is rotation osteotomy. And if it is between 4 and 8 years, okay, previously I used to do triangle tilt surgery. Triangle tilt is a very complicated surgery with limited results. And it also has a lot of morbidities. Now I have moved on to glenoid anteversion osteotomies. These are osteotomies which are done just beneath the glenoid fossa to get the scapular glenoid fossa of the scapula a little bit more posterior, prevent the humeral subluxation. This child has underwent Mott surgery at 2 years of age. You still find that the internal rotation deformity is present in the left upper limb. What I have done is, I have done an osteotomy here. I have split and opened up the glenoid fossa, you can see the result that is happening. Okay, this movement, this is pre-op. You can see the humeral head still when external rotation is done. This is post-op. You won't see the humeral head subluxating posteriorly in external rotation. On table, you can see the result of external rotation happening in a glenoid anteversion osteotomies. For patients who have got a global palsy, we go in for a free functional muscle transfer. And this is a child where you can see the child has got limited elbow flexion, some finger movement that is happening. This is after a free functional muscle transfer. You find after stabilizing the elbow, the finger function is happening. So this is microneurosurgery when best possible. Now I've reached to the end of the session. General belief is that they will have a spontaneous recovery, I think, which is a myth. They need to be seen by a plastic surgeon and they need to be addressed. Surgery earlier than 3 months for global palsy, or at least at 3 months when there is an upper plexus lesion, is the recipe for satisfactory functional outcome. There are multiple refinements in secondary procedures. We can give better results. In severe avulsion injuries, also, as you saw in a free functional muscle transfer, it is possible to get back some function. For somebody who does not have any function, an entire upper limb is available non-functional. Giving at least 10-20% of the function is a change, life change in the patient. It has got long-term disability without proper treatment, birth brachial plexus injury. So clinical presentation is varied. Non-operative approach is to facilitate the recovery for most cases, but severe instances will require surgery. Please understand, super splint is can change the way you are handling these children. This can be, it is eminently possible to get done in every institution. Early referral is important to get optimal functional outcome. Thank you very much.
Now, with this, we have reached to the discussion and the question answer session, where we will see questions from the physically present residents and the participants, and also those who have posed the questions online in the chat box. Residents, you will get a long case. Brachial palsy. It's a difficult and challenge right from the history and then taking the examination. So it's a nightmare. But if you have a methodical way of approaching, you have made your chart ready, then everything is possible. And as sir has shown the timings, then you can adhere in your exam based on the timing, at what age the patient has come, and what all the recovered functions or the residual functions are there. So questions? 1 minute. Give the mic to her. Yes.
There's one question. You said for the don't do the triangulated. This capital elevation and the forward. I can understand how the glenoid.
Anti-glenoid.
It is called, yeah. Yes. This procedure is called glenoid anteversion osteotomy. So before deciding on whether you want to do this procedure, this is primarily done to get external rotation of the upper limb at the shoulder level to prevent subluxation of the humeral head posteriorly. This is the aim of this procedure. Okay, to do this procedure, you need to understand some basics of anatomy that is there. You have the scapula, you have the glenoid fossa, you have the humerus. The upper border of the scapula, okay, this is, there are some angles that needs to be learned. These results are given by radiologists. It can be done with ultrasound or it can be done with CT scan. With a high frequency ultrasound, it is still possible to identify these angles. It is called as alpha angle. Okay, so understand the name alpha angle. There is a line which is drawn from the superior border of the scapula, which goes to the humerus. In the glenoid fossa, there is a lip, posterior lip, anterior lip. You draw a straight line along the superior border of scapula into the humeral head, and you draw a line in the posterior lip. Okay, a tangential line going through the posterior lip of the glenoid fossa. This angle, the angle that is created between these two, is called as the alpha angle. This alpha angle is somewhere around that 25 degrees, 26 degrees, in that range. If the alpha angle is more, which means that the glenoid fossa, which is supposed to hold the humerus like this, it just got tilted. The humeral head has subluxated posteriorly. The posterior lip of the glenoid fossa is much more. The angle keeps increasing. Once it goes beyond 30 degrees, it means that this patient will require anti-version osteotomy. Because this is how you decide. Once it goes beyond 30 degrees, this child will benefit from an anti-version osteotomy. You have a glenoid fossa. You're not going to operate on the glenoid fossa, just beneath the glenoid fossa, about an inch below that. Okay. All you do is you open up the skin, identify the supraspinatus, infraspinatus muscle, retract the infraspinatus muscle. You will be reaching the lateral border of scapula. As you climb up, you will be reaching the glenoid fossa, the articular surface. About an inch below the articular surface, you do an osteotomy. Initially, you do only the posterior cortex. The anterior cortex is intact. Once you do an osteotomy at that level, you just start splitting it. Because if these are small children, you put an archiforceps and spread like this, the glenoid fossa will keep moving up. Okay, this will move up and move anteriorly. What it does is now you have got a cavity which is shallower to posterior aspect. The humerus will slide easily. If you have done an osteotomy, you've lifted it and you've transferred it anteriorly. What happens is this humerus cannot slide back. So humerus essentially goes into external rotation. The shoulder goes into external rotation. This is glenoid anteversion osteotomy. You do an osteotomy, and this will work when the child is between 4 and 8 months of age. In a triangle tilt osteotomy, I work on the clavicle, I work on the acromion, I'm working on the humerus, multiple osteotomies, and a big change is happening. And all these are fractures which are created by us, which has to heal. Okay, at 3 points when it has to heal, it is tough. If it is healing at 1 point, again, in this place, I will put in a bone graft. Once I split, you have to retain that split. To retain that split, what I do is scapular spine. I would take a small bone graft from the scapular spine, put between the split scapular base, and put a plate and screw over there. Okay, this will ensure that it doesn't come back to its original place. So this will make sure that the glenoid fossa is moving tilted anterior and a little superiorly, so that the humerus doesn't slide back. It is in position and goes into external rotation instead of internal posterior slide and internal rotation. This is the idea of anteversion.
At what?
You have to go to such center and assist him.
Yeah, we have now got a series of about 15 cases of glenoid anteversion osteotomies.
It's not
We are likely to publish it.
so completely or easily done. So you have to really.
Once you see it,
Yeah,
once you see it, you will be able to
Not
understand.
everyone is doing
Sure.
Yeah, not everyone is doing this procedure, but yes, Saraj understood so well the anatomically the principle behind it, and there is a glenoid and the scapula behind. And later on, you can always. I was looking at there when sir was saying there is a. So you can understand the line which sir said, na superior.
I would like to share,
Yeah.
if possible, I will share some
Yeah, after the lecture.
papers on how this is done. There are some fantastic papers. First time I registered for a brachial plexus conference. This time at Thrissur, I had presented 2 papers there. The first time I got registered, I have never been to a brachial plexus congress, but I've done these procedures. So when I did this and when I presented and came down, there's one orthopedic surgeon by name Maulin Shah. He does a lot of these glenoid anteversion osteotomies. He was greatly impressed. He said, "You also come to our center. You see how we are doing."
I think green also small description is there. I think it is not there even because sometimes When you have understood and you are able to reproduce the result, so then it becomes a really
Yeah. So once it is done on a regular basis, automatically you will find a way. You want some solution to this child or to this problem, you automatically find a way. To
But does it require that extensive ultrasound
No,
proper?
Yeah, a good ultrasound or a CT scan will be able to pick it up. And because these are bigger children, they are say in the 4 years to 8 years age group, they will be able to withstand CT scan. When they are very small children, they are not properly sitting. You need to sedate them, and once you sedate them, the parents are a bit apprehensive. Those kind of scans. So my choice is less than 1.5 years. I would always do a nerve repair. 1.5 to 4 years of age, I do a mod quad procedure. Again, this mod quad has got 4 elements to it. You will do a latissimus dorsi to infraspinatus, teres major to teres minor, decompression of the axillary nerve, and a subscapularis release. The original Rahul Nath procedure describes the subscapularis release very close to the insertion. What I do is I don't, because once you reach the subscapularis insertion close to the joint, you might be damaging other structures. So what I do is I make an incision in the subscapular, in the lateral border of scapula, elevate the periosteum anterior to the scapula, detach the origin completely, slide the origin. Once you get the origin periosteum out of it, now it will not heal it in the same place, it will heal a little lateral. So
Like
this,
we do, like we do.
Pec
Like,
major also originally.
so what sir is telling, like we doing Bachmann ischemic contraction, muscle slide operation.
yeah,
So in the muscle, when you are not cutting, you are just sliding it. Then it will heal where the gap is there.
yeah,
So there will be a pseudo formation and there will be a, and
Yeah.
what we want, it is achieved also as well as
we are not dividing the muscle, and what we want also can be achieved. That is the modified version of Rahul Nath's procedure. Yeah,
contraction, we do
yeah.
muscle sliding operation. So same principle sir is applying at the different region.
And once it crosses that 4 years of age, till about 8 years of age, this glenoid antiversion osteotomy works. Once it crosses the 8 years of age, this may not be sufficient. You may have to do a rotation osteotomy of the humerus. Again, you have to be very careful in doing a rotation osteotomy of the humerus or a mod part. Any of these procedures that you're trying to correct the internal rotation. There are some midline activities like buttoning the shirt, keeping belly in the center, or tying the knot, braiding the hair. These are midline activities. When you want midline activities, some internal rotation has to be there. Okay, if you try and provide excessive external rotation, internal rotation doesn't happen. It becomes all the more difficult for you to get back internal rotation. So you have to be very careful when you're doing procedures for external rotation. Make sure that you are not limiting internal rotation so that the midline activities are not effective.
So one more question. Sir, FFMT at what age do you do, sir, for pediatric?
Global policy
As
has
the
no
age
reason.
increases, as the Sarah said, simple principle. Early the patient, better the neurolysis, better the nerve repair, then the muscle transfer, and because as you are more fibrosis coming, more changes are developing, secondary changes are developing.
This question of pre-functional muscle transfer, I'm working from about 2005. For 20 years, what I have learned from pre-functional muscle transfers in our center, any muscle transfer or a tendon transfer for that matter, a tendon transfer will work well as you go more distant. Fingers, you have to move very little. Wrist, you have to move a lot. Elbow, a lot. Shoulder, if you have to do a tendon transfer. Many people, after having done a trapezius transfer, claim an abduction of what 90 degree, 120. It does not happen. This whole upper limb has to be lifted. Such a huge one has to be lifted by a trapezius muscle. It will give you about 30 degree abduction. It will prevent the humerus from subluxation. That is what it can do, a good trapezius transfer. Getting 90, 120 degrees, I don't think it is possible with the trapezius. This is a muscle which is available with you. All you have done is a tendon transfer. When you're doing a free functional muscle transfer to get excellent results, I don't think it is possible. It is okay for getting finger movement. It is okay for getting elbow flexion. And for children, if it is global palsy, all are gone. C5 to T1 is gone. Everything is gone. You have some nerves that are available. If you see the children early, my preferred choice would be to use the nerve, not the muscle. So I would use, as sir said, spinal axillary nerve, intercostal nerve. Intercostal nerve is a little difficult to harvest in children. Spinal axillary is much more easier. I can use the phrenic nerve. I can use the contralateral spinal accessory nerve. All these are possible. Sometimes I have used the hypoglossal nerve also. I've split the hypoglossal, I've used the hypoglossal nerve also. But for getting finger and elbow flexion, you require functional muscle transfer. Generally, I wait for about 3 to 4 years. When all attempts have been made, all things, whatever possible has come, and it is not possible for me to get any movement with the existing nerve and muscle, then I plan for a free function muscle transfer.
And finally, osteotomy, as I said, when nothing is left in the bone. So you start with the soft, you go to the hard.
Yes.
Any other question? Residents?
So, in post-scan journey, do you prefer nerve transfer or nerve graft?
If a proximal nerve route is available, you always make use of it. 100% if some proximal nerve is available. The number of axons that you are getting from a root, C5, 6, 7, 8, T1, that cannot be matched by any other nerves that are available. If there is a proximal route available, it is healthy, then you always either try to do a repair or bridge it with a nerve graft, do something, but try to use the proximal nerve. But you can use it much more carefully by giving it only to the motors. For example, if you have a C5, I will not repair C5 proximally and C5 distal. You can give the C5 to the lateral root. So it will go primarily to the motors and less to the sensory so that motor recovery happens much better. So those kind of things can be done. We are working on, we have done only one case, we are yet to come out. We are trying to put the nerve back into the spinal cord. Reimplantation of the nerve back into the spinal cord. This is extremely difficult. We have to bridge it with a nerve graft. You use a nerve graft, connect it distally. Proximally, where you want to attach it to the spinal cord is a question. The moment you open the vertebra and see, it will be whole white. You won't know which is C5, which is C6. Nothing can be picked up. And if you try to repair it like this, nerve to nerve, if you try to repair like this, you will do harm. You can damage some lower limb axons. So what we do is we take the nerve graft, attach it side to side, put a glue and only one stitch. And what into the spinal cord. Yeah, definitely. Without a neurosurgeon, you can't do. You have to do it along with a neurosurgeon because it is in the neck C5, 6 at that level. And doing this will be helpful for shoulder, sometimes for the elbow. And forearm, nothing. Only for shoulder, C5, isolated C5 root avulsion. You can.
The choice of nerve grafts, you can take within the plexus, something that's not functional or.
If see, for what reasons you want to use it, this is important. If it is a partial injury, for example, isolated C5, 6 injury, C7, 8, T1 is intact. You would always aim at close target neurotization. You do an Oberlin's procedure, 1 and 2. But for getting shoulder abduction, you use the spinal axillary to suprascapular. I would prefer, nowadays I am preferring to motorize the axillary nerve rather than the suprascapular nerve. Deltoid recovery becomes more important than recovery of the supraspinatus, infraspinatus, which gives only initiation of abduction. So I make sure that if there is C5 cis alone injury, it's a low hanging fruit. You can get good results with that C5-6, isolated C5-6 with a spinal axillary to suprascapular, then a Sohm-Sachs procedure and Oberlin 1 and 2. You do all three, you will have excellent results.
Do you
But-
combine the SN to SSN and then do the Sohm-Sachs?
All at one go. All at one go. You can do all at one go. You put the patient in supine position, do spinal axillary to suprascapular, and then you shift the patient to lateral position, do a Sohm-Sachs.
We did that yesterday.
But without
Yeah.
position change.
Yeah, without the position, you can put it in lateral position and do all of them. But putting it in lateral position and doing it, exploration at the neck level, you need to bend a little bit. You still will be able to do, because age is on your side, your spine will be okay after doing the surgery. When you grow older, you bend like this and do Evening 6 o'clock, 7 o'clock, you'll find some backache. As sir was saying about Dr. Antia, so you will slowly start developing backache because these are procedures will take it takes 3-4 hours, and you want to do it consistently for long periods of time. You have to find the right position, do it very comfortably, and then get it easier.
Okay, we'll see the chat also. Kavita, just check in chat. Yes,
Yes.
If somebody has posed. So most of the questions are in the form of appreciation. So thank you very much, sir. Lot of appreciation coming and including from Dr. Farooq from GNK. Yeah, he is our regular. He is omnipresent, so he will be present in all the CMEs and one of the really academician, I would say. So he has written wonderful talks, very crisp and well presented. Congratulations and a big thanks to you. So we will also, and then welcome to the live. Remember to guard your privacy. So anything else? That's all. There is only, so it means it was very clear. But actually it was very clear. The approach was very clear that when to do early. The earliest. Message is very clear. Don't wait for that. Usually mindset is as sir has said, yes, recovery will occur. So actually you want to recover or the nerve will recover. So you don't have to recover, you have to attack if you really want to help the child. So that is the one message.
Can I add on?
Yes. Give the mic. No, then you can-
Not a problem. See, what we are working now is on adult brachial plexus injuries. These are pediatric. We are yet to put. We are working on adding tacrolimus to these patients with adult brachial plexus injuries where we have done a nerve repair or a nerve graft or a nerve reconstruction in any form. We find that the rate of recovery has changed from growing at about 1 millimeter per day. They are getting about 3 to 4 millimeter per day. The problem with tacrolimus is first evaluation whether the patient is fit to take those medications, to look at the blood counts, and second, some of them have gastrointestinal disturbances. So if they are very comfortable, this is something which is giving better results a little earlier. So that is something in which we are working on. And right now we are working on, there is a department of hand in IIT Madras. Okay, they are working on hand functions. We are working on normal hand.
Bionic hand also.
Yeah, they are working on normal hand. They are doing lots of physics research in normal hand. Normal hand, this much vector, this movement, that movement is happening. I brought them. See what is happening to these patients. Oh my God, this is something beyond our comprehension. They are working on normal hand. What changed is now they are trying to get us. This being a government setup, all spent force, all those patients will come. 5 years after pan palsy, nothing is available to them. Painful upper limb, all those kinds of patients will come. So entire upper limb is available but cannot be used. So what we are working now is on exoskeleton. We attach something to this hand and it does elbow flexion. It does finger flexion. So grasping a tumbler, taking it to mouth, drinking water. So this we are working with IIT Madras, and we have this is available across in many countries in Europe and US, and it is a little costlier. We have come up with a lightweight, less costly variety of exoskeleton. Shortly it will be into use, and once it is put into use and used by the patients, maybe we will be able to say something about it.
So Dr. Friji also joined during the panel discussion because he was in OT. So sir is our HOD. So we had a lot of discussion regarding the brachial plexus, especially the pediatric one. And a lot of things have been, in a very streamlined way, sir has told. So thank you. A difficult topic, but you made it very easy. And any other question? Any other question, comments? So today we have covered two parts, the regeneration part and the reconstruction part. So regeneration, we have here anti-aging and regenerative clinic, which we started in 2012. So that is what how we are making multiple layers and we are trying to regenerate wound, which is very common problem. Otherwise, also other regenerations. So conduits, nerve conduits, so those kind cartilage, like as you said, tacrolimus. Many people they are adding regularly during the when they have done the reconstruction, especially in children, to expedite the growth factors, stem cells, and preventing the fibrosis. So people are taking the technology also help. So that is what just want to give a comment. So with this, we will go to the next part, and that is the our thank you to the guest speaker. And I request our head of the department, Dr. Friji, to hand over the memento and a gift item to sir.
And a brief introduction. Yes. Thank you.
And also this.
Oh my God, this is quite a big box.
Yeah. And inside it is empty. That is why it is beautifully covered. We'll give the cover also to make it easy to carry. And the participation certificate is routine, sir. Your participation certificate
Oh, thank
to
you.
submit to your department.
Yeah.
Because that the frame cannot be. So now I request our chief guest and the HOD to come, and Dr. Padma also can join to give the participation certificate to our physically present candidates here. Sir, please come here. And then those who have joined online will be getting his certificate. Dr. Anand is there. Dr. Anand. Rita is exam going, so she is not here. But she is exam going. Yesterday only theory over. Dr. Bharat Prakash Reddy. Kannab is in OT. Kannab is in OT. Okay. Dr. Priya, receive your participation certificate. So Shrinath, come. Okay.
I have not told all the people. This is a difficult topic to.
Dr. Dhana is there? Dhana is not there. Dhana, Dharmeshwar, Dr. Rashmi, Dr. Rashmi. Rashmi is now exam going.
I had
Yeah.
actually got.
Because this to sub center, we have matrix of the trade. Dr. Shrinath. Yeah. You'll be very happy, sir. Usually, Dr. Ayushri. Vigneshwar is there? Vigneshwar? No, sir. Vigneshwar is not there. And Raja Ganesh. And then those who are physically coming, sister, please come. You can write your correct spelling and name, so we left it blank. See to me.
The UK very important role in management of these meetings.
But these people will be there some or the other way, in the OT or post-op period. They should be sensitized. What actually, anyone left? Anyone left? Sure, all okay, please, have a seat. So we have done the participation also, and now I request our assistant professor, Dr. Padma Lakshmi, to deliver vote of thanks, and then followed by a group photograph will be there with us, our speaker and chief guest. Yes. Our sponsor from Coco Hill, they also want to. Yeah, is all with the support of our mayor. Thank you for bringing him here. Sometimes they don't listen to us. But they will listen to you. Because they are more close, they are meeting, Raghuram. No, I am host.
2 minutes.
But I am host.
Yes.
Dr.
Yes.
I am host. How
On behalf of Cookie, You like the-
Okay, we have submitted for publication. Thank you.
I thank you very much. Our HOD has given a time. And really thank you very much for thanks for us.
Okay, now I request Dr. Padma Lakshmi, Assistant Professor, Class Surgery, to deliver vote of thanks.
This was.
Good evening, everyone. First, I would like to thank the administration of JIPMA for giving permission to conduct this program. I would like to thank our head of the department, Professor Dr. Priji, and our faculty, Professor Dr. Ravikumar Chitoria, Professor Dr. Devi Prasad Mahapatra, Professor Dr. Dinesh Kumar, for organizing this informative CME program, providing a valuable platform to learn about the latest advances in healthcare. I'm especially grateful to Professor Dr. Ravikumar Chitoria, sir, Professor Senior Scale of Plastic Surgery, Associate Dean Academic, Registered Academic, Head of the IT and Telemedicine, JIPMA Puducherry, for his talk on regenerative scaffold vessels. And our guest speaker, Dr. R. Sridhar, sir, Professor and Head, Department of Plastic Surgery, Government General Multispecialty Hospital, Chennai, for joining us today and sharing his invaluable expertise on the cocoa bean-based wound dressing management and birth tracheal plexus injury, a race against time. Both talks have offered invaluable perspectives, and such knowledge sharing is vital for advancing patient care in plastic surgery. I would also like to express my sincere gratitude for the sponsors of today's program, Adol Biomed India. I would like to thank the JIPMA IT wing for helping us telecast the program, and also would like to thank the staff of the Department of Plastic Surgery for arranging the hall for the program. Finally, a big thank you to all the participants who have joined us offline and online. We look forward to conducting more CME programs in the future. Thank you.
Now I request all of you to rise for national anthem.
जनगण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
Thank you, Jai. With this, we are closing the session for online, and physically we will have a group photograph of the participants with the chief guest and the HOD and faculty of the department. Thank you once again. So, you can tell me here.